Hi guys, welcome to Essence of Medicine. Today we're going to talk about the history of Trans-Kambin OLIF. I'm Amanda Armagast.
I'm Dr. Abbasi.
I'm Ken Barra.
Now, Trans-Kambin approach is a method of getting to the spine, into the disc, to perform a spinal fusion. But as well, it has been used to do decompression, meaning that's the approach that we get to the spine, either to trim what push on the nerve, but as well, recently, very recently actually, to perform a spinal fusion. And for people who are not familiar with that, spinal fusion is imagine your discs are like the tire of your car, and some tires are done. Their life expectancy is done, they are in pieces, and we have to take that disc completely out. At that point, most of the time what we do, we take the bad disc out, put a spacer in that we call a cage, and then put screws above and below that level to stabilize that level, so spine doesn't literally, the bone doesn't grind on the bone. We have been doing spinal fusion for last 70 years. Not very successfully, though, I may add. The standard of care for spinal fusion is the standards actually, one procedure called PLIF, posterior lateral lumbar interbody fusion, which is practically 50 years or 70 years old. It was brought in 1950s. The most frequently performed procedure is called TLIF, or transforaminal lumbar interbody fusion. That is brought actually to medicine by Dr. Harms in Germany in 1980s. There are other methods of getting to the spine, but today we are going to talk about Trans-Kambin approach. What I need to add as well to that this Trans-Kambin approach is becoming very popular. Many surgeons across the United States and globe are performing it under different names. The name we use for that is oblique lateral posterior lumbar interbody fusion, which is OLLIF. You shouldn't confuse with another OLIF ATP, which is oblique lateral interbody fusion anterior to psoas, that is going through the belly. Our approach is all from the back. Some other people call it other names like the ENDOLIF or are you familiar with other names that other people use for this
For
procedure?
a minute, there was KLIF for Kambin.
Yeah, KLIF for Trans-Kambin approach, but that really didn't become popular. But ENDOLIF is something that people use for this procedure.
The endoscopic approach, yeah.
Yeah, and but more or less, it is going through a Trans-Kambin kind of anatomical structure to approach the disc. This, by any regard, is going to revolutionize the spinal fusion, and the indication is all there. As a matter of fact, some people who are not familiar with that are panicking. Why? People who are not spine surgeons are performing it because they can.
I was just thinking about that radiologist who did that. Did you see that LinkedIn post about the radiologist who did the spine fusion?
Was that the Dr. Beal we talked about yesterday?
Yes.
I've known Dr. Beal for many years, and he actually did an OLIF technique more than 5 years ago, probably.
And he's very good at it.
He's very skilled, yeah. Interventional radiologists have exceptional experience with doing things on imaging, using fluoroscopy to place a needle or do whatever their procedure. They're very good with imaging,
and they are good with technology, and they are early adapters.
Yes.
You know when else other surgeons really panicked when interventional radiologists start doing things? The list is so long. Kyphoplasty, it's interspinal process, cardiac cath, brain cath, coiling, stents. Every time we're disciplined, failed to understand the value of a project, of a process, of a technology, interventional radiologists took over. They got really good at that. And at first, the surgeon, my people, at first they laughed about it. After that got really acceptance, they panicked about it and tried to bash them. And unfortunately, 10 years later, they tried to adapt it and tried to keep pace with the interventional radiologists. And for certain things, they never did. They never were able to catch up. And those things become interventional radiology. I, as a surgeon, I see myself first as a physician. I do believe if somebody can take care of the patient with proper education, They should. Just because some people are becoming territorial, we shouldn't hold them back to provide care, by the way, a care that same surgeon didn't want to provide. So, so this is going to be a revolution in the spine surgery. And what I'm doing here with my team is creating a record for posterity. So we are going to talk about the history of this, and we are going to mention names of the people who were involved in that, because this is truly a record of the history in process. Imagine most of armies these days, they have their own historian. They gather the data for when there is a war or a conflict, they gather the data as you go. And this is like a prospective study of the history that we are doing today. So I think it's important for the background that people know who we are, who is reporting this history. I'm Dr. Abbasi. I am a board certified neurosurgeon. I got involved with the OLLIF about 10 years ago after I couldn't perform certain surgery for certain group of people who were in need. So my involvement here has been the last 10 years. I have published 11 peer-reviewed papers for the OLLIF procedure. I have trained a significant number of the people who performing the OLLIF. And providing care.
Specialist, and one of my main goals here is to kind of educate the public.
Ken Vera, I'm a mechanical engineer. I've been working on since around 2010. Name names. I'm going to first apologize if I forget some. I don't accurately.
It should be acknowledged. About their work. Now, if we forget somebody, the title of this podcast is Engineer's Story: the history of Trans-Kambin. Next week, who's going to come on and give us the surgeon's story. Even though I have been involved in 2012, since 2012, they have been involved in people ask me, did I invent the OLLIF? No, I didn't. But that's exactly what. So, tell me about 12 years ago. Well, what were you doing? What were you doing? What name will they use? Start choosing the name. What name already chosen?
At that time, I was working for Amendia. 2008.
How did you get involved? How did you get?
Engineering was a second career for me, and I was finishing my degree, and Amendia was very close to the university where I was finishing. And I got and then stayed with the company. And
Which university?
it was Southern Polytechnic State University is where I finished my degree. I started at Georgia Tech on vacation. So yeah, I started working for Amendia in 2007. In 2008, it actually became Amendia. And
What was the name for that?
spinal devices.
Spinal devices. Okay. How many people were in that?
When I started, I think there were 6 people.
That's it.
And, one machinist, shop manager, he was the president of operations, and his partner Tim Jenkins was financial and inventory shipping. Myself, and then that was myself.
Now, what was the vision of the people who were running? What they were? I mean, there are like 10 major company, if not more, in the spine.
Yeah.
What they were trying to do that was different, or what were the vision to creating that company?
Well, at the very beginning, with that small kernel of people, it was we were making some devices that were called Casper pins for anterior cervical. They're fixation pins used for that. And
Do you want to explain what that is? Because you told me
Okay.
that was a big deal then.
So, well, the Casper pin is used for an anterior cervical approach. You put it's a stainless steel screw that's about 15 millimeters long that goes into the bone, and I think it's about 50 millimeters long sticking out of the bone. And you put them in the vertebral bodies above and below the cervical disc where you're doing the surgery. Then you put a retractor over them. It slides over the long extended pin, and you use that to distract doing the cervical procedure.
It's a commodity, but from conversation you and I had before is that you guys just did it very well, and then
very
market
efficiently.
it very efficiently, and then
Direct marketing to the surgeries centers and the hospitals, and being able to provide an equivalent product at a lower price,
And
without,
that-
taking away that structure.
and that made Amendia financially strong enough to think about other things. Is that correct?
That was Spinal Devices was doing that, and then incorporated a few extra people. Tracy Anderson and Jeff Smith came in to form Amendia. Jeff was our CEO. Tracy was our VP of Sales, and Tracy had been a distributor for many years in spine and had connections with surgeons in the Southeast. And we worked with Dr. Randy Bishop originally to develop a pedicle screw system. That was the first, real major spinal implant product for Amendia.
Where is Dr. Bishop? He's
He's in Savannah, Georgia.
So he's
Yeah.
still practicing
He is.
now?
He's still practicing. Yes.
Excellent. I think we connected even to him not long ago. And so now you're a group of under 10 people at that point. When you went from a spinal devices to Amendia or something like that.
Right.
So tell me what happened then.
In 2008, Amendia kind of came together with Jeff Smith as the CEO, brought in investors, and brought together the team that, became Amendia. And soon,
What was the point that they said, we want to be Amendia, or do you have any backstory about how the name come around? And
Amendia was a name that was brought together from two different pieces of Latin root. I think we can credit Jeff Ratcliffe with that. Amend means fix, and ia makes it a group. So it's a group of people fixing something,
okay,
That's a
nice.
really cute name.
fixing
That's a cute
spines,
name, yeah.
fixing
Yeah.
medical device, and we came together with a new kind of very agile approach to be able to do things. We had a small core of engineers. We had our own internal manufacturing, and the engineering worked very closely with manufacturing so that we could optimize exactly what was being done. And then just working in that team and working closely with surgeons. First with Dr. Bishop, worked with him. I spent a lot of time in Savannah in the OR observing him. And
What was your first impression of being in the war?
well, actually, it wasn't with Dr. Bishop the first time. The first time was with a different surgeon, and he was doing a traditional PLIF approach.
Okay.
So I think it was probably like a 3-level surgery.
How long did it take? What was the
It was probably
Efficient.
2 hours.
okay? So that
and
he's a very efficient
efficient for
surgeon.
PLIF, yes.
Yeah.
Yes.
So 3 hours for a 3 level.
What's the standard?
For
How long?
1 level, the average is about 3 hours for 1 level.
Yeah.
So
this was a
3
long
hours.
time ago. I might not have my timeline perfect,
Mhm.
but I do remember, he's removing the supraspinous ligament, the spinous process, the lamina, the ligamentum flavum, taking out a lot of natural structures.
Which is required for that
It
kind
is
of
for a
surgery.
PLIF. You have to expose the spinal cord and
Yeah.
then manipulate the spinal cord to access the disc.
And that is what it takes a long time.
Mhm.
Okay, now
And a lot of bovie, a lot of cautery,
cooking
a lot
the
of blood loss.
tissue, yep, all that. Now
That was
fast
my
forward,
first experience
Yeah.
with a PLIF.
fast forward 12 years. 2 days ago, I did a 3 level. I'm not sure if you got the statistic of that case.
I haven't seen it yet.
Well, did a 3 level, L1 to L4 in 57 minutes, 144 cc of blood loss, and that patient is being discharged. Actually, was supposed to be discharged yesterday with the weather and so on. Probably going to be discharged today. on an 85-year-old patient.
Wow.
So 12 years forward, that is the foundation. What you're describing is the foundation of what we are doing today, which is by any standard is a miracle of technology. So, Cliff, what happened then? Tell me about how did you guys transition? What is your first memory of developing devices and things? Who were involved in that? And
Dr. Bishop at the time was using a minimally invasive approach from Spinology, which is a mesh bag that's placed. And it goes through Kambin's triangle, and it uses similar instrumentation for the approach.
So Kambin triangle as an approach to the spine has been established before that.
Well, yeah. I mean, Dr. Kambin was using it for endoscopic approaches to the spine.
In 1980s, actually. Yeah. That technology, that knowledge went to Asia, and just in the last 10 years is making it back, meaning we in the United
Endoscopic
States.
decompressions, have been very popular in Asia.
Doctor, and this might be controversial, but I'm going to say it because our job is investigate the history. Dr. Kambin developed this approach in 1970s, and nobody wanted to adopt it in the United States. The technology actually went to China and Asia, South Korea, Japan. Just in the last 10, 15 years, it's making it back from there to us. And we literally, like electric cars, we invented it, we neglected it, and it's coming back. And Dr. Kambin lives and does surgery in Pennsylvania.
What was the reason it was kind of rejected here at first?
That is good. Would be a good question for a historian. That I'm not saying that, but if instead of Parviz Kambin from Iran, if his name was Will Smith from New York City, would have been different. Or if he would have been one of these eminent people in the spine, we talk about evidence-based medicine. Nothing is further from the truth. It's mostly eminent-based medicine. Few people, few names, they decide what is going to be taught in the universities, and everybody follows just because they say so. And few catchy names like robot and so on, they get just thrown around, and everybody follows in a way, in a fashion. But that is a good question for historian. Why something that we invented in the United States has to go to China, South Korea, Japan, become perfect there, and then come back, and now we are 20 years behind them. Literally, we are 20 years behind the technology that we produced because other people adopted to that. What were the root cause of that? We don't appreciate things that we don't appreciate our own technologies that we develop.
Well, and it's still not really appreciated because the big players, they're still against
They fight us. They fight us all the
fighting
time.
it.
But this is meaningless now because patients know what's the difference between going home next day or going home in 2 weeks. Patients do understand what's the difference between losing half a gallon of blood or a cup of blood. They understand what is the difference between, the patient truly understand now what's the difference between 5% of infection and 0.17% infection. People truly understand that. But talking about the technical development there, so Trans-Kambin approach have been there before for a long time.
Yeah, and used with endoscopes. And then I mentioned Spinology's OptiMesh procedure used that approach.
How long has that been in use? And were all the early adapters for OLLIF technology, were the OptiMesh users, Spinology system users?
Two of the very early users, yes, they were using OptiMesh. That was Dr. Jerry Schell and Dr. Randolph Bishop were the two first doctors I remember collaborating with on that.
Okay. Now, so they were doing this Trans-Kambin approach, and I just know how the surgeon minds is. Our question is always, what can we do better? The problem with that bag of bone is literally in the OptiMesh, what you do, you go through the Kambin triangle, you put a tube in. Now, the tube has a certain size. You cannot put a cage through the tube, but what you can do, you can put a bag of bone.
Yeah. So you put a polydacron mesh into the center of the disc, and then through a very small tube, you pack bone fragments into it. And so you have the bone that's filling the bag, and you're basically building a sandbag inside the center of the disc. And, it had a lot of merit. You could do hydraulic distraction, you really could see that the bag would grow and push the end plates apart. One of the common issues that the surgeons that I was working with were experiencing was that they, for whatever reason, the bag would either break and the fragments weren't contained anymore, so it wasn't maintaining its height.
Mm-hmm.
Or in a few instances, the bone that was being packed into it was being resorbed by the body and not redeposited.
And it's not the effect that separating the bone, restoring the height of the disc, is many times not permanent, because that mesh of bone, that bag of bone, cannot really keep its shape the way you always wish for it to keep the shape. So
It's
they
not
were
rigid,
thinking,
right.
yeah. So these surgeons, they are good surgeons, they see the potential, they want something more, something different. Tell me, go from there.
So, yeah, that comes down to Dr. Shell saying, we really need a rigid device that can go on this same approach, that can enter the disc and be rigid and not be resorbed and not change shape, even if it doesn't immediately fuse, which then led to the development of a PEEK implant. There was a company in Texas that had a product that was a kind of a conical tip lift device or T-lift device. And it was a merger of, a few different ideas at once to take a conical tipped implant and
Was
put
it
cannulation.
cannulated?
It was not cannulated at the time.
Okay.
And that was where the team that was working with Dr. Shell, and it was Tracy and Alan and myself that were working with Dr. Shell on the project, had the first cannulated implant, and we didn't have cannulated instruments right away. So, there was a cannulated implant that we could do the discectomy through a tube, leave a guide wire inside the tube, and then remove the tube. And that guide wire would maintain the pathway to the center of the disc.
So emerging technologies and ideas. Trans-Kambin approach has been there for a long time. Through the OptiMesh, you knew you can do a discectomy. You knew you can work and trim the disc and so on. And what was still in development is that how do you put that rigid spacer, which we call a cage in? And obviously, that I think at some point somebody's mind, like a light bulb, went on that you don't have to keep the tube in place and insert the cage through a tube. In that case, then you're not limited to the size of the tube for injection of that spacer, as long as you keep the trajectory. But I think
so. That was Dr. Shell who said,
Yeah.
let's cannulate the implant and put it over a wire. And then
how big of a deal was to cannulate the implant?
drilling a hole through the implant was the simplest thing ever.
Yeah.
It
Who did
was-
it?
They did them at Amendia. We manufactured them in the factory at Amendia.
Yeah.
And then developed the instrumentation to go along with it, the cannulated
Which
inserter.
is the inserter, yeah.
And then all the devices for accessing the disc, the access portal, the discectomy tools.
Were they mostly developed at that point or not yet?
It was kind of a hodgepodge of things that we had worked with different systems, different kinds of minimally invasive approaches that had different kinds of devices. And it was refining those combination of those multiple devices that were present in other systems, but refining them and making them all work together as one system.
What year was that?
That was 2010.
2010. Now, I remember I joined you. I was in Amendia in 2012. In 2010, when you guys start doing that, how many people were in Amendia?
Wow.
A dozen, 2,000?
Maybe 20.
20, about
Yeah.
2,000 people.
Because we'd already been developing a pedicle screw system.
Yeah.
And then beyond that, we developed a facet screw system. And then that's why I was working with Dr. Shell was the facet screw system. And then the OLIF implant came from that. And then, we had other doctors that we were working with, and that's where Dr. Talley came into it.
So he's early adapter. Next week, we are going to have Dr. Talley telling the surgeon story. Now,
I apologize to any surgeons who I've left out of this brief history.
Yeah, and if you remember that, they should get due credit. We will add it to our
And
podcast.
I should also state, I was one of several engineers that worked on this project.
Yeah.
It was not 100% me.
But you
I was
were,
part of a team.
the whole team was 20 people. And I want to emphasize how much of a big difference is if you are a 20 people group or if you are 2,000 people group. A 2,000 people group can never be agile, can never be, you just, and we'll come back to that. But one of the reason major things happen in somebody's garage is because few inspired people get together and put their energy in a concentrated way to make something out of the box. And that was and is still out of the box kind of thing. So in 2010, is that the year the first OLIF, the way we perform it, or rudimentarily was performed?
I didn't take great notes in a history book then, but that's from memory, yeah.
Yeah. And were you there? Or
oh, yes, I was at the first implant
You
procedure.
were there. So this is a piece of history right here. You were there when the first OLIF procedure was performed. Can you just recite from your memory what you remember from that?
It was actually a revision of a previous surgery where one of those Optimesh implants had been, the bone had been resorbed, and it was approaching removing the what was left of the containment bag with no bone in it, and then implanting a peak OLIF in its place.
So, I mean, how long did the surgery take? What was the first impression of you, of the surgeon, of the staff? Was it in the hospital? Was it in a surgery center?
It was in a hospital in Saginaw, Michigan, and Dr. Shell was performing the surgery. And,
so he performed the first OLIF procedure
with the cannulated implant that we know it as today. Yes.
Okay. So go ahead.
And like I said, it was a removal of a previous implant that hadn't fused, and finished it up very quickly. Dr. Shell's a very efficient surgeon. I'd
Under
say
1 hour?
I believe it was, less than an hour. It was, I mean, he was already doing the Spinology Optimesh for
so it was
a couple of years, so
very,
he was very
comfortable
with the
approach. Yeah.
And he very efficiently removed the old, put in the new. I don't remember what the fixation was for that case, if he added new or I don't remember the detail there. But it was a very, very quick, very efficient case.
Yeah.
What was the energy like afterwards? Like, were people pretty excited, or was it kind of another
believe-
day? Because I know
Didn't quite
surgeons
know
don't
where-
get so excited.
People,
didn't
most
really
of
know
them
where
don't
we're headed.
register. Yeah. Most of the time, when something major happens, like the moment that the Fleming noticed that, wow, look at my petri dish. Bacteria are not growing when there is a mold there. Most of the time, people in the moment don't recognize the truly the significance. Years later, the significance get out. But that's you were observing medical history at that point.
Yeah, I was there, for technical support. All the instruments that Amendia had developed, I was there to represent that and take the feedback and drive that into further development of the instrumentation.
And that was 2010 as well. So what was next? What happened after that?
Working with more cases with Dr. Bishop, more cases with Dr. Shell.
So Dr. Talley, what was one of the major people who started that early adapters?
He was an
and doing
early
that.
adopter, and the further development and refinement of the surgical instruments and the technique and the teaching technique. And I want to say at the time, Dr. Katzell was involved with that too. Whenever I read the surgical technique guide, I hear Dr. Katzell's voice. That's Jeff Katzell from Boca Raton, Florida.
Yeah.
He
and I have talked to him as well. I have talked to all these doctors, by the way, but I know them personally. Go ahead.
And so over the years, working with more surgeons, working to, refine the system, refine the technique, the teaching, all the methods of it. Had opportunity to work with surgeons outside the U.S., all around the U.S. Saul Campson was another doctor that was doing endoscopic techniques.
Unfortunately, he passed away about 2 years ago on pancreatic cancer. Yeah. Now, something is special about Dr. Campson. Tell me, what's special about Dr. Campson?
Dr. Campson was not a orthopedic or neurosurgeon.
He was an anesthesiologist. And he got lots of grief from the surgeon societies and surgeons because he was doing surgery. But he was a good friend of mine, and he was good at what he was doing. The problem is here that there is a emerging technology. The same thing with the Dr.
Beal.
Dr. Beal.
Yeah, Dr. Beal did OLIF interbody placements maybe 7 years ago.
So let me just narrow it down. You're 85 years old. You're in horrible pain. You're about to gather your pill to commit suicide. You go to 5 spine surgeons. Yes, this is a critic on my colleague. You go to 5 spine surgeons. They just want to get you out of their office because you are a liability. If they do surgery, they want to help you, but the surgery they do is not a suitable surgery for an 85-year-old who need a 3-level fusion or anything with cardiac problem, with heart problem, lung problem. They just want to get you out of there. This patient, they are desperate. They go to anybody who can give them any help. And now in this situation, there is a demand for something else. People like Dr. Kamsen or Dr. Beal have an option for these patients where we surgeon, we send them out. We send them out. We said you have to go and live with that. And they are helped with Dr. Kamsen and Dr. Beal. They get the surgery done, and then people like me go on LinkedIn and just...
Well, not people like you.
Well, I'm just talking about as a surgeon.
Other surgeons who aren't adapting the procedure.
Same surgeon that who criticized me for taking care of this patient, they go and say, you're not a surgeon. I'm going to start doing heart surgery. You know what? If you're trained, that is about one of the comment. Well, I'm going to start doing heart surgery. If you're trained to do heart surgery and you can help the patient, you should.
Yeah.
Whereas, this territoriality of this is nothing short of a self-pity, because you have the opportunity to help this patient or even send the patient to somebody else, but yet you choose not to help the patient and you criticize people who are taking a huge liability on their career. Now imagine if something, I'm a trained neurosurgeon, spine surgeon. If I have complication, I can justify it. Dr. Kamsen or Dr. Beal, that is for them huge personal liability, yet they choose to help the patient. So I want to give them a medal, okay? This is the fact of it. The amount of the risk they take on career, whereas for me, sending that patient out of my office, I'm not being safe to that patient. I'm being safe to my career by saying, no, go away from me because I don't want to take that risk on my practice. But we say they should go live with that. In truth, when they stop walking, they decondition. The average life expectancy is about 6 months to a year for somebody who quit walking. So Dr. Kamsen, and which was a good friend of mine, and now Dr. Beal are doing this. So this is jumping beyond the circle of the spine surgeon. What was the the atmosphere there? How did that, like Dr. Kamsen got involved in that? God bless his soul.
He was doing endoscopic decompressions, so he was very familiar with the anatomy and the approach there, and he recognized that some of his patients needed more stabilization.
Mm-hmm.
He had a partner in his clinic who was an orthopedic surgeon, so they would collaborate on those cases, and Dr. Kamsen would do the approach and get into the disc space and deliver the implants.
Now, he had quite the volume, right? To my best understanding from my memory when I was talking to him, where at that point, I'm assuming there were like a core of a dozen or less of a surgeon performing in 2010, 2011.
Yeah, it was probably 2011 to 2012 before it reached a dozen.
Yeah,
it was not immediately jumping to that level. It was,
what number was I?
Progressing.
What number was I?
Gee, I'm not sure how many. I didn't make a lot of notes. I was just busy doing all the work.
So there is a dozen of surgeons performing this, and I'm sure you knew every single of them because.
Yeah, I'd say up until there were more than 30 surgeons involved, I probably had met with each of them, been in the OR. When a new surgeon would come for training, I was part of the cadaveric training labs. I had a special team of engineers that worked with me that were out in the OR getting feedback, performing those
Mhm.
training visits, and if somebody had their first surgery, um, the surgeon comes to a lab, but the rest of the OR team doesn't get that experience,
Mhm.
and it's a lot for one person to try and explain all the steps that have to happen for the team to move together through the first surgery. So we would send somebody to assist and have
Were
an
you
extra
that
set of
person most
hands.
of the time?
I was frequently that, and I had two other key guys that I worked with, Zolt, Chase.
Yeah.
Um, those were the guys
You
that.
want to tell their full name if you remember?
Yeah, it's Chase Thornburg and Zolt Cernatoni.
Okay, well,
Those were the
you
two
recorded.
guys that they flew all over the country and outside of the country to go and
Where outside
support
of the
this.
country?
Oh, I think Zolt one time went to Australia and China.
Okay.
I personally went to Istanbul, Germany, England, Mexico, Colombia, and Brazil,
Okay.
and probably 40 something states.
Now, one of the things I noticed that Amendia trained lots of surgeons, but very few actually kept doing that. And you tell your take on that, and I'm going to tell my take on that.
Well, I think a lot of the training events were attended for reasons other than training on the procedure. It was more for surgeons to come and interact with the executive team at Amendia and have a chance to see what we were doing, but they weren't really there focused on OLIF. That some of them were, but not all. So I think the number of surgeons that attended versus the number of surgeons that really wanted to participate might not have been high ratio.
Now, I'm going to tell you my take on 2012, and that is again report of the history. In my previous place in Sioux Falls, South Dakota, I had very effective access surgeon for OLLIF. It's a surgery that you open up the belly, you go to the disc from the front after pushing major vessels, major organs to the side, and that is totally depending on the access surgeon. And and I was doing a lot of them, and I was good at that. But that's a surgery you always need access surgeon. When I moved to Alexandria, Minnesota, at that time, I tried to cooperate with local surgeon, but I noticed the approaches are going to take more than 3 hours. The same approach that was half an hour in the previous place, and that wasn't suitable for me because in a private practice, it's not. I cannot spend that long in the ward just for the approach. And I was looking for alternatives. And the Pete Sanchez, who was a rep, independent rep at that time, told me that he knows of a surgeon, which we found out to be Dr. Talley, doing a one-level fusion under 1 hour. Mm-hmm. And to understand, I'm well trained. I'm trained over 13 years, and I was really good at TLF, and I needed about 1 hour 45 minutes. Now, most of the thing is, and this is human nature. We surgeons are A-type personalities. We are machos. And the time how efficient we are, not fast. How efficient we are in the war is our point of pride. And when somebody told me that they do that surgery that they're doing almost 2 hours under 1 hour, my response was, "I'm important, so bullshit." But I think my blessing was that I didn't just stay there and walked away. I said, "Bullshit, I want to see it." And then we flew there and I saw it. And I can just tell you, my chin dropped on the floor. And for me, it was a light bulb moment that what I just noticed, what I just saw there is a diamond, but it's not refined. It can be much better because the surgery, the room were very crowded. The steps were very, very, it is going the right direction, but I noticed that so many things can be done better. And I filmed that, I took pictures, and I talked to Dr. Talley and so on and so forth. 10 years later, that surgery was, I actually measured that, it was 56 minutes, one level, and most importantly, I watched that patient going home. The world changed for me in that moment. Now, 10 years later, I do a 3-level fusion in the same time frame by refining the protocol, by refining the step, by refining the instrumentation, by the way, with less blood loss. And so, but I noticed that something, I'm observing something very, very special. Now, what as well I noticed at that point, that imagine you have a machine gun, but you are just using it as a like a one click at the time, one bullet at the time. I noticed that not even the people like Jeff Smith and the other people in your group, they truly understand what the potential of this is. I noticed that they are sitting on something that can change the entire spine, technology, but they are not truly utilizing to its full potential. And I had many conversations with them and so on, like say, you need to get out of there. You need to push it out there. But they were very conservative by any standards, They didn't really want to get out of their shell for whatever reason and go and slam the landscape with this technology. What was the internal, after you guys have been doing it for a year or year and a half, what was the internal discussion among the engineers, among the top executive there? What was going on in those board meetings? Was I just annoyance? Because I know that I talked to everybody about what are you guys doing? This has to go out there. What was the perception there among when you guys were talking internally about OLLIF, especially before and after I start doing the cases?
I don't remember specifically a lot of discussion about any one surgeon. It was more
No, but I'm talking policies, strategy.
How to expand the exposure. We were doing things at like NAS, where we had a cadaver lab as associated with NAS, or doing training labs associated with groups like SMIS, or I'm trying to remember the others. But yeah, doing training labs, trying to just reach a broader market, and a lot of it was connections through distributors, connections through surgeons that heard by word of mouth that
the traditional device way of expanding things.
Yes.
The traditional, yeah. Okay.
And that was before social media was available, and you couldn't really do that kind of marketing that has changed the landscape in the last 5 years.
You never went to patient, you went to surgeons, and as a company. Okay. Now, let's fast forward 2012. How many surgeons do you think, just guess, were involved in 2012?
Maybe 10.
10. So I think I was in the winter of 2012, February, March, around that time, or maybe even a little later, maybe in the spring, I did my observation there. And I come back home, and I start doing the cases and slowly increased my volume. When I noticed that, I'm getting really good at it. And one of the problems I noticed is that, that I am like, in a new land. There's really, nobody has written a book about what can go wrong and things that can be done better. I have to literally experience everything for the first time myself. And many times I tried to, get connected to your group. In 2012, how many people were you there? 30, 40?
Trying to think of the timeline, if that was probably after we changed buildings. I think the first time I met you was when we had moved to our larger building.
Yeah.
That might have been about 2013 or so. I think you'd already been doing the procedure for quite a while when I remember first talking
Not with
you.
high volume, but yes, I have been doing it for a while. Now, one of the things I noticed that there was a device. I just needed to be a little different. I remember you and we talked even on the phone multiple times regarding that. But what I do remember, it took me somewhere between 4 and 6 months to just get to you. I mean, otherwise, I was talking to Pete. Pete was talking to you. I was talking to Ryan Dickinson, and who is not engineer, who is
Ryan's the
sales
manager.
Yeah, and you know how the sales people are. They always pretend they're 100% paying attention to what you say, and they 200% understand what you are saying, and 300% are going to make it happen. But at the end of the day, I don't believe he really would understand as a salesperson, which is not engineer, what the problem was and how I wanted to fix that. And I don't believe even he had the authority to make that change I was requesting until I got to you. So in that 2013, 2014, what devices, what part of the devices were you developing? Because to my best knowledge, you have developed most of the actual instrument that go with this procedure, correct?
I was part of it.
Yeah.
You know, I can point to certain instruments and put certain engineers' names on them, and I was not the hand on every piece of it, but I was involved with the team and bringing it all into, you know, coalescing it all together.
No.
I spent a lot of time traveling and being in the OR, and there were a lot of guys that worked in the office and put together all the nuts and bolts and details of things that while I was traveling, they were working on those details.
No, yeah, specifically, I remember, you know, I was doing a cadaver lab in Seattle. You,
Yeah.
you,
That was a few years later.
yeah, that was few years
That was
later.
2018, maybe. That was it was right before the election where Trump got elected.
Yeah. Well,
Right before that.
Well, I remember that I was doing the cadaver lab, and so at that time I had like probably 250 to 300 cases under my belt, and I had so many ideas that, you know, things that could get better. And when I came to the cadaver lab, tell what happened then.
We were there to do a cadaver training. We had a new instrument that one of the young engineers on our team had been developing, Brian Dickinson.
Okay.
I'm sorry, Brian Daffinson.
Okay.
Apologies, Brian. Brian had been developing that instrument as it on the handle end. It looks a bit like a rongeur or a pituitary rongeur, and on the far end, instead of biting, it had a triangular flip that, as you articulate it, it would flip up and down. See my hands?
Yep.
And then when you have it half articulated, you can push, pull, scrape against the end plate with it. And it would pass through the access portal into the center of the disc. And we just needed to do some validation with it. We wanted to have it in a cadaver lab so that we could get some feedback and do our validation studies. And after the lab was over, it wasn't there anymore.
Well, I did tell you that I'm going to take it with me. It wasn't just vanished, but because I knew what all the things that it makes the procedure easier or harder, I knew that it's going to make a huge difference, and I did not want to delay that care to my patient even a day. You so told me you're going to send it to me, a version of it, and I said no, I want to take it with me. Because once you know something is going to make impact on outcome of your patient, if you don't burn to make it happen, you don't deserve to be a physician. If you know something is going to do, if you know there is a possibility of something to make an impact and you don't go educate yourself regarding that, honestly, I don't believe you deserve to be a physician. If there is a way you can help the patient better and you don't at least go and investigate it with all your heart. So I did not give that device back to you because I was convinced that's going to make an impact on my patient care.
What were you guys saying? Like when you
they were laughing about me. That
I think thieving bastard was thrown around a few times. But those devices, they were totally processed. All the paperwork was done on them. We were just doing our final validation. So there was no concern about the device being in the OR.
Yeah.
But it was one of those things where it just wasn't on plan. It wasn't our timeline. And then I was cleaning everything up. I'm like, he wasn't joking. He really took it with him.
Now you know him well enough.
Oh, now I know. Yeah. I don't leave things laying around.
No.
And no, this is actually people think it is by chance that I do a 3-level fusion in 57 minutes and with half a cup of coffee, blood loss, and send them home next day. People think it's by chance that when 5 surgeons are told the patient, you will die of surgery. I do that surgery in 1 hour and change their life. They are in 3 weeks off narcotic and so on. That kind of dedication has expressions.
I think the thing that needs to be expressed here is it's not that you're just doing a 3-level surgery in a short time, but the fusion is evident. You have results. We have studies that show that this is not just a quick surgery that didn't really address the problem. you really are getting
We have
fusion.
end results. We have actually not even more than fusion. We have the clinical result that we have 1,200 patient testimonial. Patient you just took one yesterday
I
from
was
a
just thinking
Jehovah's
about
Witness. What were you feeling? Because that patient, Jehovah's Witness from yesterday, was told the same. You cannot be helped. You will die of that surgery. What was your feeling when you were giving
I
that
was feeling
interview?
proud.
Yeah, but you want to tell in the podcast what that was about?
Yeah, the patient was a Jehovah's Witness and she was a little bit overweight. So,
A little, yeah. The BMI was above 44, so it's a high BMI patient.
and that was actually one of her concerns with getting the surgery from another surgeon. So she was really happy when she found Inspired Spine and how much safer it was. Her daughter is actually a nurse and her daughter was doing the research for her.
So practically, that patient was told cannot get a surgery, and we delivered.
And
She's
now her
pain
pain's
free.
gone.
She's pain free, and she was willing to drive to us and get the surgery done. But that is the kind of to develop, go from that point to that point. There is a need for a few inspired, dedicated people, and I think that is you see many of them here in this podcast. And next week we are going to talk about the medical story of that. Now, from you have been briefing this to close this podcast about the early development from 2013 until now. What was when I started, making like all these noises and so on, talking to Amendia, you are not being aggressive enough and so on. Was any internal talk about it or was I just a troublemaker? What do you remember anything about that?
He wants you to tell him he's a troublemaker.
No, but
Well,
I want that.
I won't deny that. But, no. No, I don't really remember a lot about anybody being negative at Amendia. It was more of a, we have focuses, we have different projects that we're working on. It was trying to expand Amendia's portfolio to be a broader portfolio that could treat different approaches that would provide solutions for different surgeons that were not only focused on the MIS approach.
So OLLIF was not the crown jewel. OLLIF was not the main 100%.
No, it wasn't 100% buy-in. It wasn't we weren't going to be a company that only did that. The Amendia was developing lateral, TLIF, PLIF, ALIF, retractors for lateral, different pedicle screw systems, cervical, different cervical plates, multiple cervical interbodies.
And I think that's the difference between then and ARM, right? ARM, the OLLIF is truly the main goal. We found out what really works, and instead of being good at 20 things, you want to be good, beyond good, the best, spectacular on this. So what is the difference between what you were doing then and now? Ken?
Well, I mean, the implant has changed. Now it's got a curvature that was commonly common question from surgeons that when it was a peak interbody and it had a flat surface was, well, it doesn't really match the end plates. Why isn't it lordotic? Why doesn't it have this and that? So ARM's version of the implant is titanium, which bone has a great affinity for titanium, where bone kind of actively ignores peak.
But as well instrumentation, but as well protocols, but as well the setup in the OR. I don't. Nobody told me how I should set up the device, the X-rays and so on in the OR.
Yeah, I wish I'd been able to come and visit you on your first case. I might have been able to
but
move
you see
a few
that
steps forward on that.
But we don't let the people any longer guess those things. No, we have the whole protocols.
ARM does a lot as far as training and support and making sure that a skilled surgeon is there for the first surgery, not just an engineer waving his hands, but a surgeon who can who can participate.
I get my, I have my state license in 50 states. I have my credential in the hospital. They do the surgery, and I go and make sure that they get the post-learning curve result from day one. They don't have to guess, because a dirty secret as spine surgeon is that once you're done with the residency and fellowship, you go, if there's something new, you go to a weekend course and you come back. Literally, you do it until you learn it. And this is not good enough for this. So I'm there with them. I'm teaching them from day one with the entire palette of the knowledge that we bring to the table to make sure they have the post-learning curve result from day one. Now, I know you have a flight to catch, so we are going to cut it short here, but this is not our last thing. Next week, we are going to talk about the surgeon's version of this. And if you have time, you should join us. And if you have any additional information, you should just chip in when Dr. Tali comes. And
Is he going to join by Zoom or is he going to be
by
here?
Zoom. No,
We
he's
can
going to
Zoom
come by
him.
Zoom, and we are going to do that. Now, but we are sitting on the tip of an iceberg here. Their potentials are tremendous because spinal fusions are not a rare disease. Amanda, you did the research. How many spinal fusions were performed last year?
Over 1.6 million.
This is a public health issue.
But I always, whenever you ask me that question, I always want to reiterate that's how many spinal fusions were performed.
Not like this
Not-
Jehovah's Witness that couldn't even get it.
Well, yeah, Jehovah's Witnesses a lot of times can't get the
Or very
procedure because of
higher
blood
BMI,
loss or high
elderlies.
BMI, elderly, too young. There's a lot of people turned. What percent of your patients are turned away by another surgeon?
About 1/4 of them.
So you could almost multiply that.
Yeah. Well, now we are going to come to the closure here in this podcast, and we talked about the early engineering, technology, and so on. We are going to talk about the medical part next week, so stay tuned. Any closing remarks? No? So
No, I want to thank all the great people I've worked with over the years that contributed to all the wonderful designs of the instruments, the great manufacturing team that I got to work with that took our crazy ideas and made them
Yeah.
reality.
and every idea is crazy until you realize it.
Until somebody takes up the challenge and makes it
Yeah.
happen.
That's what
I've been
definition.
very fortunate to work with some really skilled people that could do that.
And
that-
as I guess I do have one closing statement that as someone who's not a medical professional, I'm really thankful for all the work that you guys put in.
Thank you. Well, now that is the definition of the outside of the box. That it's crazy until somebody put their life work on that to make it possible. For Essence Podcast, I'm Dr. Abbasi.
I'm Amanda Armagast.
Ken Barra.
Thank
Thanks,
you.
guys.
Bye.
Merry Christmas. Don't worry. Okay, thank you. I give you a right. Do you have a right already?
No, I don't have a ride yet.